I'd like to thank the SAGES Committee for this opportunity to present our work. My presentation is entitled Endoscopic Ultrasound, a Powerful Tool to Modify Treatment Algorithms in Opioid-Induced Achalasia. I have no disclosures. The use of opioid pain medication has significantly increased over the last 20 years. Currently, 4% of the adult population in the US routinely uses opioid analgesic medication for pain control. Opioids are associated with a number of well-known deleterious effects, including sedation, dizziness, respiratory depression, and physical dependence. Furthermore, opioid receptors densely populate the GI tract, resulting in symptoms and side effects in both acute and chronic opioid users. These effects do not diminish with continued usage. The motility-associated effects of opioids occur in the stomach, small bowel, and colon, and are collectively referred to as opioid-induced bowel dysfunction. Symptoms are variable and may include early satiety, nausea, vomiting, dyspepsia, bloating, abdominal cramping, and spasms. The specific effect of opioids on esophageal motility has become a growing topic of interest. Narcotic use has been shown to lead to symptoms of dysphagia and heartburn. A recent study involving healthy volunteers showed that administration of morphine decreased both duration and magnitude of swallow-induced lower esophageal sphincter relaxation with effects reversed by naloxone. High-resolution manometry in the opioid patient subset frequently demonstrates impaired lower esophageal sphincter relaxation, high integrated relaxation pressure, and low distal latency, consistent with the manometric pattern seen in patients with primary achalasia. Furthermore, opioid-induced esophageal dysfunction was more likely in patients taking a higher median 24-hour opioid dose. Conventional therapies for primary achalasia, such as Heller myotomy and pneumatic dilation, are directed at reducing LES contractility, decreasing functional obstruction, and increasing esophageal emptying. However, these treatment approaches have not been effective in the treatment of opioid-induced esophageal dysfunction. The objectives of our study were therefore to determine the utility of endoscopic ultrasound in differentiating primary achalasia from opioid-induced achalasia based on degree and length of esophageal round muscle layer thickening, and subsequently to attempt to clarify a management algorithm in patients with opioid-induced achalasia. We performed a retrospective review of a prospectively maintained database to identify patients undergoing evaluation for suspected achalasia from 2016 to 2019. Suspected achalasia was based on clinical presentation in the setting of objective studies concerning for achalasia. Patient characteristics collected included age, sex, BMI, and achalasia subtype. Exclusion criteria included prior esophageal surgery, history of esophageal malignancy, and prior pneumatic dilation. Clinical documentation was reviewed to assess for concurrent opioid use at the time of workup and intervention, and patients were stratified into opioid and non-opioid groups. Patients within the opioid group were identified based on the CDC definition for opioid use, defined as opioid use on most days for greater than 3 months. Opioid dosing and type were collected and converted to morphine equivalents. The baseline assessment of all patients included endoscopy, high-resolution manometry, upper GI swallow study, and endoscopic ultrasound. High-resolution manometry data points collected and compared between the two groups included integrated relaxation pressure, distal contractile interval, and distal latency. Of note, EOS is performed as standard of care in the esophageal dysmotility workup at our institution to rule out pseudoachalasia. With regard to measurement of the esophageal round muscle layer during EOS, the thickness of the round muscular layer was measured at the esophagogastric junction, with measurements performed at 1 centimeter increments moving proximally. The maximum round muscle layer thickness in millimeters and the length of thickening exceeding 1.8 millimeters were obtained. Currently, no standardized threshold for abnormal thickening of the esophageal round muscle layer exists. Based on the current literature, we use the Wilcoxon rank sum test to compare round muscle layer thickness between opioid versus non-opioid groups, starting at 1.3 millimeters and increasing in 1 millimeter increments. 1.8 millimeters was noted to be the inflection point for the upper limit of normal between the two groups and was therefore selected as our threshold. Descriptive data were compared between groups. Categorical data were presented as count and compared using Fisher's exact test and chi-squared, while students' t-test was used for continuous variables. The EUS measured maximum round muscle layer thickness and length of abnormally thickened muscle were compared between suspected achalasia patients on opioids versus not on opioids using the non-parametric Wilcoxon-Rank sum test. The independent samples t-test was used to obtain the 95% confidence interval of the difference in maximum round muscle layer thickness and length of thickening between groups. A total of 45 patients met our inclusion criteria. Chronic opioid use was noted in 12 of these patients, or 26%, while 33 patients were not on opioid therapy. Demographics between the two groups were similar. Mean age in the non-opioid group was 56, while mean age in the opioid group was 58. BMI tended to be higher in the opioid group, with a mean of 30.2 as compared to 26.8 in the non-opioid group, although significance was not achieved. Achalasia subtypes between groups are shown here. Additionally, no significant differences were noted in high resolution manometry data points between groups. Within the group of patients meeting criteria for chronic opioid use, indications for opioid therapy included chronic neck and back pain and osteoarthritis. The mean duration of opioid therapy was 4.7 years, ranging from 1 to 10 years, and average daily dose after conversion to morphine equivalents was 55 milligrams. The EUS measured round muscle layer thickness of opioid users presenting with symptoms of achalasia demonstrated a median of 1.8 millimeters as compared to the median in non-opioid users, which was 2.7 millimeters. This approached statistical significance with a p-value of 0.05. The length of round muscle layer thickness greater than 1.8 millimeters was statistically significant between groups. Opioid users had a median length of greater than 1.8 millimeters of thickening of 0 centimeters, while non-opioid users had a median length of thickening of 4 centimeters, and this was statistically significant. We performed a subgroup analysis to assess EUS measured round muscle layer thickness within the opioid user group based on 24-hour morphine equivalent dosing. Patients taking an equivalent dose of greater than 45 milligrams of morphine daily had a mean thickness of 1.2 millimeters versus 2.4 millimeters in patients taking less than or equal to 45 milligrams of morphine daily. This is a representative image showing a thickened circular muscle layer in a non-opioid user measured as 5.3 millimeters with an image of a non-thickened circular muscle layer in an opioid user measured at 1.5 millimeters. The distribution of procedural interventions between the two groups is shown here. Within the subgroup of patients who underwent procedural intervention, symptom resolution was noted to be higher in the non-opioid group. Conversely, reintervention for persistent symptoms was elevated in the opioid group as compared to the non-opioid group, although statistical significance was not achieved. Taking these findings into consideration, our group has modified our approach to patients with symptoms of achalasia in the setting of active opioid use. Our workup, as previously mentioned, for suspected achalasia involves a barium swallow, upper endoscopy, high-resolution manometry, along with measurement of round muscle layer using endoscopic ultrasound. In patients with active opioid use, we attempt opioid cessation first when feasible. If procedural intervention is indicated, we now preferentially offer Botox injection or pneumatic dilation. Since 2017, we have not offered hellermyotomy to patients with opioid-induced esophageal dysfunction. Limitations of this study include the retrospective nature of our data analysis and small sample size. Additionally, we have a heterogeneous grouping of achalasia subtypes. In the future, larger studies would be beneficial with breakdown into different achalasia subtypes. In conclusion, opioid cessation should be the first-line approach to opioid-induced esophageal dysfunction. Other alternatives include decreased dosage of opioid therapy or switching to tramadol as an alternative approach. We have found that endoscopic ultrasound mapping of the esophageal round muscle layer thickness may be a useful modality to help differentiate opioid-induced from primary achalasia. We believe that incorporation of EUS into the standardized achalasia workup may help tailor treatment strategies to optimize outcomes for these patients and potentially help avoid unnecessary interventions. These are my references. Thank you for your time.